Here I have listed some of the high-yield GI disorders that you will have to know for your Step 1 exam, and so in a separate video I have discussed the GI disorders that are common causes of lower GI bleed. So here I'm just going to focus on the other disorders which are listed on the right-hand column. So the first disorder is the Hirschsprung disease, the other name for which is congenital aganglionic megacolon, and this condition is caused due to the failure of neural crest cells to migrate, as a consequence of which there won't be any Auerbach and Meissner nerve plexus that are being formed, and these nerve plexus are required for the relaxation and dilation of a GI tract. So if these nerve plexus are missing, therefore there would be a portion of a GI tract that is narrowed and will not relax, and that would cause obstruction. And so due to the failure of the colonic relaxation, these patients present with constipation, bilious vomiting, abdominal distension, as well as failure to pass meconium, which is the first feces. And so here you can see that I've listed that these patients present with bilious vomiting. So just to quickly summarize the difference between non-bilious and bilious vomiting. So you know how the stomach will join the duodenum, and then the gallbladder is draining into the duodenum. So any condition that causes obstruction before the duodenum, like for instance the pyloric stenosis, will cause non-bilious vomiting, because these forms of vomitus cannot mix with the bile that is from the gallbladder. On the other hand, any type of obstruction that is after the duodenum, now the GI content is being mixed with the bile, and so obstruction that are after the duodenum will cause bilious vomiting. And so Hirschsprung, since it's affecting colon, which is distal to the duodenum, will cause bilious vomiting. Now, as for the risk factors to Hirschsprung disease, Down syndrome, also known as trisomy 21, is one of the common causes of Hirschsprung disease, because in these patients neural cross cells fail to migrate, as a consequence of which there would be lack of the Auerbach and Meissner plexus. And then for the diagnosis of these patients, you have to order rectal biopsy, which is the gold standard test, and this type of biopsy is being done by mucosal suction technique. And so on biopsy, if the ganglions are missing, then that would confirm the diagnosis of Hirschsprung disease. And so for the treatment of these patients, you have to surgically resect a ganglionic portion of the GI tract and then connect the rest of it to the anus. So you know how here the dilated portion is the normal portion, while here the narrow colon is a ganglionic section. So for the surgical treatment, this portion needs to be resected, and then the dilated portion needs to be extended to reach the anus. The next condition is hypertrophic pyloric stenosis, and this condition is generally absent at birth but will develop within the first 2 weeks of life, and it has been associated with the use of macrolides later in pregnancy or in neonates, and macrolides medications include, for instance, azithromycin, clarithromycin, erythromycin, and so on. So the use of macrolides in children increases the risk of hypertrophic pyloric stenosis, where on examination you will see a palpable olive mass in the epigastric region. And this keyword is very important that you will continuously encounter on the exam. So if on the exam you see that there is a child that presents with a non-bilious projectile vomiting after feeding, and then on examination there is an olive mass in the epigastric area, then you must start thinking of pyloric stenosis, and then the underlying cause, if they ask which of the following antibiotics is possible cause of it, would be the macrolides. And so as I just mentioned, these patients present with non-bilious, again it's important, projectile vomiting after feeding. And so it's non-bilious because the pylorus is before the duodenum. As for the diagnosis, you can diagnose with the ultrasound, and then the treatment can be done by pyloromyotomy, where there would be incisions made in the pyloric muscles, or it can be done by balloon dilation. The next condition is duodenal atresia, where there is a closure of a portion of a lumen of the duodenum, as a consequence of which these patients present with gastric distension and bilious vomiting. So since the gallbladder has already emptied inside the duodenum, therefore bile is mixed with the GI content, and so these patients will have bilious vomiting. And so one important finding that you will see on the X-ray is a double bubble sign, where you see that here we have double bubbles. And so this double bubble sign is due to the dilation of the stomach as well as the proximal portion of the duodenum, which presents with two bubble signs on the X-ray. And then risk factor to duodenal atresia includes Down syndrome as well as annular pancreas, where there is a congenital abnormality characterized by a ring of pancreatic tissue that is surrounding the descending portion of the duodenum, and thus it will cause duodenal atresia. The next condition is intussusception, which is a telescoping of a bowel segment into its distal segment. So here you can see how the proximal bowel has telescoped into its distal bowel. And then here on the CT scan, you can also see that two bowels have telescoped into each other. And so it's thought that the intussusception, which is commonly seen in children, is due to the viral infections, like for instance rotaviruses and adenoviruses, which will cause lymphoid hyperplasia, which places traction on the intestine, as a consequence of which it will cause telescoping of proximal segment into the distal segment. And then the GI part that is most commonly affected is the ileocecal junction. And the presentations of these patients is a current jelly stool. So the stool that these patients have is such a thick bloody stool that it has a current jelly appearance, and so that's why the name current jelly stool is given with patients that have intussusception. And so as for clinical presentations, these patients present with a sudden onset of crampy abdominal pain that occurs at 20 minutes intervals, and then the pain keeps on progressively getting worse with every episode. And then for the diagnosis, you can use ultrasound, and treatment is with non-operative reduction by air enema. The next condition is volvulus, which is due to the twisting of a bowel that will cause obstruction, as a consequence of which it will cause impairment of the vascular perfusion, and if it's not fixed soon enough, it will cause infarction of the bowel. Now this condition, unlike intussusception, which is more commonly seen in children, is more commonly seen in elderly patients. And the site that is most commonly affected by volvulus is the sigmoid colon as well as the cecum. And so the clinical presentations of volvulus is a slowly progressive abdominal pain that presents with nausea and distended abdomen. And then eventually, after several days, these patients start to vomit. As for the diagnosis, you can order a CT scan of the abdomen, and for the treatment, you can order flexible sigmoidoscopy to untwist the sigmoid loop. But then if it's too late already and bowel has undergone infarction and the patient is presenting with peritonitis, then you will have to proceed with laparotomy to resect the infarcted bowel. The next condition is Meckel's diverticulum, which is due to the incomplete obliteration of the vitelline duct. The other name for it is omphallomesenteric duct. And so here on this image I have shown you the omphallomesenteric duct, which will help connect the yolk sac, which provides the nutrient, to the primitive intestine in the embryo. And so if this omphallomesenteric or vitelline duct does not obliterate, it will remain in the form of the Meckel's diverticulum after birth. And so this type of diverticulum is considered as a true diverticulum because it contains all the layers of a GI tract, including the mucosa and submucosa, muscular layer, as well as adventitia. So now let me ask you a question. What's the difference between true and false diverticulum? So false diverticulum doesn't have all the layers of a GI tract, and in fact it only contains the mucosa and submucosa. And an example of a false diverticula is, for instance, Zenker diverticulum. On the other hand, the Meckel's diverticulum is a true diverticulum, and thus it contains all the layers of a GI tract. In any case, back to the topic. So the Meckel's diverticulum is due to the incomplete obliteration of the vitelline duct. The other name for it is the omphalomesenteric duct. And so the Meckel's diverticulum may contain ectopic gastric or pancreatic tissue that will cause ulceration and bleeding from the adjacent mucosa. And it's usually the distal ileum near the ileocecal valve that is being affected. And so the general presentations of Meckel diverticulum is painless rectal bleeding at around 2 years of age. And then for the diagnosis, we use Meckel scan, which uses the nuclear medicine study in which the 99M technetium pertechnetate, which has affinity for the gastric mucosa, which is also found in the Meckel's diverticulum, will help this type of scan to detect Meckel's diverticulum. So here is an example of Meckel scan. And so here you can see that these are the arms of the patients. Here we have the abdomen. This is the other arm. Here we have the bladder. And so on the scan, the stomach. And so here you can actually see the outline of the stomach, as well as the distal ileum at the ileocecal valve has been detected by this nuclear study. So therefore here it shows you that in addition to gastric mucosa that is present in the stomach, there is also another site which corresponds to the Meckel's diverticulum. And then for the treatment of patients with Meckel's diverticulum, if these patients are symptomatic, then you will have to use surgical resection. On the other hand, if they are asymptomatic, then it depends. If it's an elderly with a lot of comorbidities, then just leave it alone. While if it's a child, since it may cause complications in the future, then you should still proceed with the surgical resection. The next and final condition is the irritable bowel syndrome, which is presenting with chronic abdominal pain and altered bowel habits in the absence of any organic causes. And so with the altered bowel habits, these patients may present with constipation, or they may present with diarrhea, or they may keep on switching back and forth between constipation and diarrhea. In addition, these patients present with abdominal pain that can improve with defecation, and then the abdominal pain is not associated with rectal bleeding or weight loss. So the characteristics of the abdominal pain seen with the irritable bowel syndrome, it improves with defecation, but the abdominal pain is not associated with rectal bleeding or weight loss. If there is in fact rectal bleeding or weight loss, then you should start thinking of other potential conditions, like for instance the colon cancer. As for the treatment, you can consider lifestyle and dietary modifications. In addition, you could consider pharmacotherapy, so it depends. If the patient has diarrhea, then you can provide these patients with loperamide, which binds to the opioid receptors in the gut, and so therefore it will decrease peristalsis. On the other hand, if these patients have constipation, then you can provide them with psyllium, which increases the stool bulk, and so again it will help resolve constipation. And so here I have one memory aid that will help you remember loperamide is used for diarrhea. So loperamide always makes me think of low fecal output permitted. So here you can see low peramide permitted. So low fecal output permitted anytime you give loperamide. So by giving loperamide, you decrease the fecal output, and so you can help resolve diarrhea. And that concludes our discussion of the different GI disorders.